lipid profile, liver function test, and thyroid stimulating hormone. First, the serial monitoring, when indicated, should include electrolytes and renal function. A 12-lead ECG should be performed initially on all patients presenting with heart failure. And in ambulatory patients with dyspnea, measurement of BNP or N-terminal pro-B-type natriuretic peptide is useful to support clinical decision-making regarding the diagnosis of heart failure. So measurement of BNP or NT-proBNP is useful for establishing prognosis for disease severity in chronic heart failure. So to the echo, mabibigyan niya sa atin yung presence or absence of mga valvular diseases, regional wall motion abnormalities, yung ating left ventricular size and function, kung may hypertrophy, may problema sa LV diastolic filling, yung size ng right ventricle. For the cardiac MRI, this is the gold standard for measurements of volumes, mass, and ejection fraction of both the RV and LV. This can characterize myocardial tissues, structure, and assess myocardial contractility. The 12 ECG naman, it can assess cardiac rhythm, hypertrophy as well. For the chest radiography, ang mabibigyan niya sa atin kung may enlargement and the pulmonary vasculature. Again, the cardiac biomarkers. For the CBC, we look for anemia, signs of infection and bleeding, which may precipitate or worsen heart failure. For the other laboratories, we assess for DM, dyslipidemia, thyroid hormones, electrolyte disturbances. So for this patient, initially I requested for 2D echo, 12 ECG, chest X-ray, CBC, serum potassium, serum creatinine. Yung iba po, on follow-up ko na siya na request like ALT, AST. For the management of heart failure with reduced ejection fraction, we have pharmacologic and non-pharmacologic. So these are the drugs that we usually give for heart failure. We have ACE inhibitors, ARBs, beta blockers, aldosterone antagonists, digoxin, ivabradine, or the ARNI or the angiotensin receptor neprilysin inhibitor. For the management of fluid retention, we can give diuretics. For the non-pharmacologic management, ensure sodium restriction of less than 2 grams per day, fluid restriction of less than 2 liters, caloric supplementation, weight loss for those na overweight, and BP control or monitoring. So in this table, you can see yung drugs na pwedeng ibigay sa different functional class. So for ACE or ARB, ibinibigay siya across all functional class. Diuretic, binibigay siya from functional class 2 if with retention, then 3 and 4. For beta blocker, binibigay siya for functional class 2 to 4, for 1 if with post-MI. Aldosterone antagonist naman, again for functional class 2 to 4. For functional class 1, yes, if the patient has recent MI. For digoxin, it is given to functional class 3 to 4. 1 and 2, it may be considered. For the management of heart failure with preserved ejection fraction, despite the wealth of information with respect to the evaluation of and management of heart failure, there are no proven and or approved pharmacologic or device therapies for the management of patients with heart failure with preserved ejection fraction. So therefore, it is recommended that initial treatment efforts should be focused wherever possible on the underlying disease process. So we manage individual risk factors, we reduce symptoms, we prevent acute decompensation, and we improve exercise tolerance. So here, review lang ng mga mechanism of action ng drug. So for ACE inhibitors, ang effect niya is sa RAAS, it inhibits angiotensin 1 to angiotensin 2. ARBs is used when the patient is intolerant of ACE. Beta blocker, it interferes with sustained activation of the adrenergic nervous system by blocking the beta-1 receptors. Aldosterone antagonist naman, for fluid, may be used for fluid retention. Digoxin, it inhibits the sodium-potassium ATPase pump. Nag-increase siya ng contractility. Ivabradine, primarily used for symptomatic chronic stable angina, may be used on top of a beta blocker for heart failure with systolic dysfunction. And yung ARNI naman, this is a combination of ARB and a neprilysin inhibitor. Ang na-research ko lang about ARNI is sold siya sa brand na Entresto. I'm not sure lang kung available siya dito. So, ang ginagawa kasi, kapag ang heart daw ay under extreme stress, it releases BNP. So this BNP, ang effect niya basically is lahat ng opposite ng angiotensin 2. So it dilates, ganyan. So however, this BNP is degraded by neprilysin. So kahit lumalabas yung BNP during stress, nadidegrade lang naman siya ng neprilysin. So itong neprilysin inhibitor, sacubitril, combined with an ARB, valsartan, this is recommended to replace ACE in ambulatory heart failure with reduced ejection fraction. So this is the initial dose and the maximal dose for the pharmacologic management. So for furosemide, we can give 20 to 40 milligrams OD or BID. For enalapril, we can give 2.5 milligrams. For losartan, 12.5 milligrams. For carvedilol, 3.125 as an initial dose. For metoprolol, we can give 12.5 to 25 milligrams OD. So for this patient, I gave furosemide 20 milligrams once a day, losartan 50 milligrams once a day, and metoprolol 50 milligrams once a day. For the non-pharmacologic management, I advise sodium restriction, fluid restriction, weight loss, and BP control and monitoring. This was referred to internal medicine. This is an algorithm of the treatment for congestive heart failure. If after the clinical diagnosis of heart failure is made, it is important to treat the patient's fluid retention before starting an ACE inhibitor. Beta blocker should be started after the fluid retention has been treated, or ACE inhibitor has been up-titrated if the patient remains symptomatic. An ARB, an aldosterone antagonist or digoxin, can be added as triple therapy. So the fixed dose combination of hydralazine or isosorbide dinitrate should be added to an ACE inhibitor and a beta blocker. So in this slide, you can see the triggers for heart failure patient referral to a specialist or program. So ito po nakuha ko siya sa American College of Cardiology 2021 update. Reasons for referral. When to refer po. So new onset of, basically parang lahat ng heart failure po yung sa kanilang update kasi new onset of heart failure, regardless of ejection fraction. We refer for evaluation of etiology, guideline-directed evaluation and management of recommended therapies. For chronic heart failure, yung may mga persistent functional class 3 to 4, matataas yung creatinine, mga frequent visits sa emergency department. I would just like to share this study that I came across with. So in this study done in 2000, they reviewed RCTs of drug treatments in chronic heart failure. So for diuretics, these are essential, according to the study, these are essential for the symptomatic management of patients with congestion or peripheral edema from fluid overload. So treatment is generally initiated with low doses of a diuretic, and the doses increase until urine output increases and weight decreases. So for ACE naman, in large randomized clinical trials, it has shown to prolong survival and reduce the need for hospital admissions in patients with heart failure. So for beta blockers, yung unang ginawa niya studies for bisoprolol. Bisoprolol next is meron silang for metoprolol and for carvedilol. So in summary, beta blockers have been evaluated in nearly 10,000 patients with chronic heart failure in over 20 randomized clinical trials. As of this time lang po ito, 2,000 pa po ito. And they have been shown to decrease the risk of death and the need for hospital admission and to improve patients' clinical status. And among the beta blockers, carvedilol yung maganda yung results kasi ano siya, non-selective siya. CA was also done to Mary Chris. I asked Mary Chris what she thinks she has and she verbalized her thoughts as baka yung high blood ko, nagka-problema na ako sa kidney. And I asked her why she thinks she has this condition and what her fears, and she responded, hindi ako makagawa masyado sa bahay kasi madali akong mapagod. So I educated her as to her health status and what could possibly cause this illness. I managed to convey to her the importance of taking her medications and controlling her symptoms. So she plans to lose weight by decreasing her caloric intake and by doing walking, but not as of this time muna because baka mag-trigger yung kanyang symptoms. She also plans to ask some help for her medications from the health center and to ask help from the local politicians. Mary Chris is willing to do her laboratory exams, however, due to financial constraints, would have to delay some of her tests just until financial aid will be provided. So in summary, this is the PFC, patient-centered, family-focused, community-oriented approach that I came up with. So basically, sinamarize ko lang po. So for the plan of management, idediretso ko na lang po siguro sa plan of management. Kasi na-mention ko na po yung iba during the presentation. So here for the plan of management, for the diagnostics, again, yung mga na-mention kong diagnostics kanina, working diagnosis was explained to the patient and described why laboratory procedures are needed. I also explained the medications will depend on the laboratory results and to relieve her symptoms. For the family focus, I did APCAR and STEAM, however, hindi ko na po siya present kanina kasi this is a clinical case presentation. Impact of illness, onset of illness, anxiety was noted because of the various lab workup and symptoms experienced. However, during explanation naman of the working diagnosis, only the patient and her sister were present because the husband has to go to work. For the community-oriented, community-based, the patient resides in Sinunuk and she has good social interaction and would participate in barangay activities. For the analysis, leg edema is a common complaint in family practice and is a symptom of various diseases, and investigation of the source of the edema is indispensable in order to manage the disease properly. On follow-up, the patient, under na kasi po siya sa internal medicine and hiningi ko lang po yung kanyang results. So as you can see, dito mataas na yung creatinine niya, triglycerides, may proteinuria rin siya +2. So upon follow-up, hindi po kasi siya nag-follow up na like siya lang mag-isa kasi under na siya sa IM. Tinawagan ko po siya but ni-refer ko siya ulit sa internal medicine. However, nung nakita nila, wala naman po silang ginawa. Bale, hintayin pa rin po yung resulta ng kanyang 2D echo. Wala pang official reading ng 2D echo niya. However, nung tinanong ko yung ejection fraction, it's 45%.